Hello and welcome back to another Invst Medical podcast. Excited to be here today. My name is Isaac and this is my second episode, so slowly improving. But today's topic is going to be chronic obstructive pulmonary disease, or COPD. But before we begin, I usually just give a small disclaimer that this is a medical advice. I don't know everything. I know very little, and I'm trying to learn by doing this podcast and going along this learning journey with all that's listening. So also, these guidelines and information that I've gathered is of August 2023. So medicine is always changing and we have more information, and obviously research is going on all the time. So this is as of August 2023, what I've learned. And also I'm in Australia, I should say, because I saw the last podcast and people were listening overseas. So these are mainly Australian-based lessons, but of course, it's going to be comparable to other health systems. So let's get into it. And I follow a pretty simple structure for how my podcast goes, which is: what is the disease? How does it present? How has it happened? What is happening? What's actually going on? How do we investigate it? And how is it managed kind of in a broad sense? So let's start with what it is. So obviously, as I said, chronic obstructive pulmonary disease. And I think it's easiest to think of these in two arms. It's made up of two conditions, one being chronic bronchitis, which is a productive cough for at least 3 months per year for 2 consecutive years. That cannot be explained by an alternative diagnosis. All right, so I think of this, and a really easy way for me to think about this is you've had 2 bad winters. So 3 months, 2 years in a row of a bad cough, and winter goes for 3 months and you have 2 bad winters. That's kind of how I think of it. Obviously it doesn't just occur in winter, but it's just a little sort of memory trick for me to remember the diagnosis. The next is emphysema, which I think a lot of people would know about, which is a sort of permanent dilatation of the pulmonary air spaces distant to the terminal bronchiole. So I recommend looking at your anatomy there and looking where those are. It helps to actually put into context emphysema. So this destruction of the alveolar walls changes your gas exchange and changes the ability for oxygen to be delivered to the tissues. So that's really important to consider from an emphysema point of view. So just to recap, we've got COPD, chronic bronchitis, and emphysema making up those 2 arms, and I gave a definition for each. So now we know what it is. How does it present? So obviously your chronic cough is going to be the key presentation. So, shortness of breath, rapid breathing as well are going to be other things that they present with. Also thinking of what you're seeing on the patient as well. So maybe they're using something called pursed lip breathing. So they're having to blow off more carbon dioxide because they're not able to exchange correctly. They're going to increase their work of breathing. So maybe they're using more muscles to breathe in and out, and particularly breathing out. This is an obstructive condition. So I always think with this, it's an obstructive condition is where you're having difficulty removing that carbon dioxide. So you're going to be working harder to sort of blow that off. And I'll discuss that more shortly. I also know that it's more of an older style of thinking, but typically there was this idea that chronic bronchitis, you have these blue bloaters, and emphysema, you have these pink puffers, and they're kind of, I guess, representations or visual representations of what you would expect someone to present at. And the blue bloater chronic bronchitis person, you're thinking, well, they're retaining a lot. So they have this kind of barreled chest shape, the blue being from cyanosis, so lack of oxygen in the blood. And they have this, I guess, increased work of breathing, peripheral edema due to something called cor pulmonale, which is where there's more right heart strain because there's more resistance for the heart on the right side because the lungs, creating more resistance, so they can have some backup to the body. Prolonged expiration, as I said, they're trying to breathe it off. And these complications of that we'll discuss later on. But then you've got the pink puffer that can present, which is more of that skinnier look with, not as much coughing, but they have something called cachexia, and that's that skinnier look that I was trying to suggest, which is where they're losing that functional muscle mass because of the breathing. And they're also hyperinflated as well, and they can have a slightly barrel chest appearance, but they're breathing very rapidly and have more of a pink skin. But that's not usually used, but it can help with your thinking to have a look at that. So I recommend that diagram might help you and might give you some points of how someone could present with that. Okay, the next point is how has it happened? So I think the key with COPD, and we're going to discuss management, is smoking. So I believe in the statistics I found was that it can account for up to 80% or 90% of cases of COPD. So long-term tobacco use, can damage the airways, lead to chronic inflammation of the airway, causing destruction and narrowing, and some of the other risk factors as well with that. So smoking, but also you can have air pollution exposure, dust, so occupational. So maybe in your history, you're asking about not only do they smoke, but also what occupational status they have, and any chemicals as well in the air as well is going to be important. There's also another condition called alpha-1 antitrypsin disease, which is a genetic condition. So antitrypsin and trypsins and trypsinogen have a role in the tissues as well, in tissue breakdown. So that's an important condition also to consider. So you could ask the patient, do they have any known genetic conditions as well if they're presenting with that? But I guess they're the key causes. So just to recap there, smoking is going to be your major risk factor, but also, occupational exposures, pollutants, and obviously the genetic factors. Okay. So the next question we ask is, what is happening within the body? So I think it's easier to sort of divide this into two kind of main headings. Well, because of the smoking, and I guess or occupational exposures or whatever the cause is that we discussed previously, you can have two processes going on, which is chronic inflammation and tissue destruction. And your chronic inflammation is going to be, resultant of oxidative stress. So that's going to perhaps affect the tissues. It's going to cause smooth muscle changes. It's going to create, as I said earlier, a pulmonary hypertension and cor pulmonale, because there's more resistance in that vasculature in the lungs. Whereas the tissue destruction is due to the inflammation, but the destruction itself increases proteases, and they actually break down the elastic tissue. And I think a really cool thing that I was once shown in a diagram was that when you lose the elastic potential of your airways to stay patent, you think of it as a tube, right? Obviously, there's laws around airways and in a tube. If you lose the elastance, you get something called dynamic airway collapse. That's where the airways will actually collapse on themselves because they don't have the strength to stay patent and open. So what you need to do to sort of maintain your airways, you have to breathe in at a higher volume to have air constantly going through to keep that airway open. I believe that's called dynamic airway collapse, and the physics laws that you can look on around that are pretty interesting and can help as a sort of a learning point to keep the airways open and understand what's actually going on in this condition. So yeah, that's kind of what's happening in the condition. So how do we investigate it? We know what it is now. We know how it presents. We know what's kind of going on within the tissues and the lungs and in the body itself. How do we investigate it? And I always use the structure. Well, we've got to do something at the bedside. We can have bloods and we can have our special or imaging as well. So the key bedside thing is spirometry. So if you haven't seen a spirometry, I recommend looking up what that device does and looking at breathing a maximal amount out as you can. So that's going to be important. And the key ratios we look at is FEV1, which is the forced expiratory volume in 1 second. So how much you can expire in 1 second versus the FVC, the forced vital capacity. And you're looking at the ratio between those, and there's obviously diagrams and the spirometry machines. I've seen some of the digital machines. They'll give you, I guess, this chart and this graph, and you'll try and follow it along and look, is there a reduced ratio between the two? 70% is kind of the level that you're looking at the ratio. And also it's important to exclude that this is a non-reversible decrease in your FEV1 to FVC, even giving a bronchodilator. So that's often important to distinguish with something like asthma, which is a reversible airway compromise or airway narrowing, right? Whereas this is a non-reversible, so the bronchodilator, still conveys a shortened or decreased FEV1 to FVC ratio. So that's going to be really important. You can always do serum tests as well. I've seen something called serum AAT, which is the alpha antitrypsin level as well. So that's if they've got a genetic things, but you would do that on bloods later on. But that's important to consider as well if you're doing that, because that could obviously affect that bedside spirometry. The other bedside that you could do as well, especially if someone's got a known COPD, is viral swabs. So do they have a a viral, infection like a COVID, for instance, or a, influenza, something like that, taking a swab at the bedside, something you can do, and they often do it in the hospital setting I've seen, but also in general practice as well. You can take a swab and see what's causing it. Another thing at the bedside is just get a sputum sample, which you'll send off to the lab. So if they're coughing up productive sputum or blood-stained sputum or whatever it may be, get a sample and you can send it off. So those are the things you can do at the bedside. But specific to bloods, obviously I mentioned the alpha antitrypsin marker. That's not something I've seen commonly done, but I know that it does exist, so I wanted to comment on that. The main bloods I have seen is arterial blood gas or venous blood gas, which can show a low oxygen or hypoxemia, and it can convey a respiratory failure, right? Is there compensation from a metabolic perspective? Is the pH low due to high CO2? And it'll give you a clearer picture there, to put it in simple terms. As well as on bloods, you can also do a complete blood count, which can show something called secondary polycythemia. So due to persistently low oxygen levels, your body's going to now increase EPO, erythropoietin, which will increase the number of red blood cells to carry oxygen. And also on your complete blood count, you would see, because of that increased red blood cells, you can see an increase in hematocrit as well. So considering those as the bloods. And then from a special investigation point of view, chest X-ray findings, there's a criteria that you can use to look at what are the common X-ray findings in COPD. Those key ones are usually the barrel chest, increased anteroposterior diameter rather. You can see, the hyperinflation of the lungs, hyperlucency of the lungs. You can have decreased lung markings as well. And you can also see a flattened diagram. That there's some key X-ray findings for you there. You can also do a CT, perhaps. Obviously, before you do a CT, you would want to know some other things about the patient, but just saying as a broad principle, you can see, certainly emphysema is something that I've seen used. They use a CT for, so that's something to consider. But often, chest X-ray is mainly going to be used as your mode of investigation. Okay, so hopefully I didn't ramble on too much there and gave at least somewhat of a structured response. I'm kind of going off the cuff a little bit with those. But yes, if I've forgotten an investigation, I apologize, but those are kind of the key ones I think that they get you through, and you could consider what are the physiological outcomes of those investigations. All right, so how is it managed? And I always say broadly, because management is going to be dependent on your local guidelines. It's going to be guided by whatever health district you're in. It's also going to be guided by what's the most up-to-date research, right? And the up-to-date, most informed things, but also access as well. You always have to consider access. What do we have access to in the setting we're in? Same with investigations. Do we have access to some of the things I spoke about earlier? So the first thing I like to think of is can you do from a non-pharmacological perspective? So before you're going to manage them with any medications, well, what we can do is firstly smoking cessation. So smoking counseling cessation, or looking at alternatives, nicotine replacement therapy. There's a whole, I guess, smoking cessation is probably a podcast episode of its own, and I recommend you're looking at that, thinking about how you're going to allow them to quit, because obviously it's such a contributor to the cause of COPD. Additionally, with that, pulmonary rehabilitation. So obviously the specialized physiotherapy that can help with improving, breathing techniques, exercise, mobilization, all those things that are a part of pulmonary rehabilitation, especially in chronic as well. The next point, the next management point is, of course, anyone with a chronic disease, you're looking at vaccinations. So, flu vaccinations, pneumococcal, things like that. And as I will harp on again, that each local area will have certain vaccinations they recommend. The guidelines should guide you into what vaccination recommendations you do. But in terms of, I guess, broadly for students listening, it's important to elicit that as a key management point. Another non-pharmacological thing is avoiding triggers. So is it smoke, air pollutants? As best you can, obviously, avoiding, respiratory infections, during flu and cold season, washing your hands, avoiding people that aren't well. I think that's going to be obviously a key part of the management. And then obviously regular monitoring and follow-up with your GP in primary care, engaging with services that can help manage COPD. There's also COPD support groups, I believe, as well. I think COPDX, and they create the COPDX guidelines, has some support information there as well. So giving, leaflets and pamphlets as well to people to educate them on COPD, as it is a chronic condition. Okay, and then going to pharmacological management. So obviously this is going to depend on the severity, and as I said, you should look at the things like COPDX guidelines, ETG, the Australian guidelines on this, if you're in Australia or wherever you are, and your local guidelines as well, because that's going to determine what therapies you use. So using bronchodilators is sort of a principle there. So I'll just speak broadly: bronchodilators, inhaled corticosteroids. I've also seen LAMAs and LABAs. Sorry, I said LABAs, but muscarinic, anti-muscarinics as well. Used as well with management of a COPD exacerbation, and then obviously oxygen therapy. So you've got the patient in front of you, whether that's an emergency department, wherever it is, you can put them in oxygen as well. And there's certain oxygen targets that you would aim for, and they're lower usually in the COPD population. So I've seen 88 to 92 is often a goal. And there's some sort of physiological reasoning behind that, which is slightly controversial, but just consider what your targets are in the COPD population, and you can look at the guidelines as well for that. I feel like every second word I'm saying here is guidelines, but it's a true statement for this, that you will need to look at that. Another thing is that you also need to consider that when you're managing an exacerbation, particularly if it's a bacterial exacerbation like an infection of a COPD, you need to look at the antibiotic regimen that's going to be useful. So looking at sensitivities and looking at your local guidelines for sensitivities, or contacting your infectious disease team is going to give you, I guess, the most important information on how to manage that exacerbation. So yeah, that's basically COPD, I think, in a nutshell. I've tried my best there to sort of cover everything. It's got a bit in it, but I think it's very useful. Especially it's been useful for me to review this. So just remembering, COPD is chronic bronchitis and emphysema. Okay, the definitions of that. Thinking of how it presents, thinking along those lines of not only cough, but I guess what's the patient in front of you looking like? What are their requirements? And then thinking about how has it happened? Well, often smoking is a large part of it, but considering other things like environmental exposures, occupational exposures, and the genetic condition as well of alpha-1 antitrypsin deficiency. Now, what's happening in the body? Thinking of that idea of chronic inflammation versus tissue destruction, I think is helpful to consider there. And then your investigations, so spirometry, which I said recommend looking at, your bloods of your blood gases, your complete blood count as well can be helpful there. Your chest X-ray findings, CT findings, if necessary. I've seen mainly chest X-ray used, and then the management principles, right? So I just elaborate on that. So there's quite a few points there in management. I may have missed some. I apologize for that, but they're kind of the broad things that I think are important. So yeah, hopefully that was useful. I'd like to thank everyone for listening along if you made it this far. So yeah, I hope that helped. So if I made a mistake or anything, or need to review that, just get in contact with me. You can comment on the YouTube video. You can message me on Instagram, Isaac Invst or Invest Podcast, and I'll do that. If you have a topic request perhaps as well, I'm happy to field that as well and look into it. So yeah, as I say, be patient with me. I'm still learning this and trying to improve, but hopefully that was a useful episode, and looking forward to seeing everyone in the next episode. And yeah, I'll see you then. Goodbye. Thank you.